Well, good evening, everybody. Welcome to this evening's webinar, Unlocking Brain Health, Insights particularly into Alzheimer's Disease. My name is Dr. Ross Grant. I'm a clinical biochemist, biochemical pharmacologist, and CEO of the Oscillating Research Institute here at Sydney Adventist Hospital, and have taught neuropharmacology for the last 20 years at one of our major medical schools. So I have a strong interest, particularly in what works in the central nervous system for people, particularly with neurodegenerative disease. So before we begin, in the spirit of reconciliation, the Adventist Healthcare acknowledges the traditional custodians of countries throughout Australia and their connections to land, sea and community. The Adventist Healthcare Limited would also like to pay respects to their elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. A couple of housekeeping for our webinar. Your microphone and video will be turned off by default. Now, you may ask a question at any time, but that's via the Q&A module. You'll see that indicated there. Please don't ask questions in the chat window. We won't be able to get to those. We'll do our best to address as many questions as we can. And please note that the webinar is being recorded. However, the audience, you as the audience, will remain anonymous at all times, and you won't be identified at all, even if you ask a question. You may also like to shift the floating thumbnail there at the bottom of the screen so it doesn't cover the speaker video. All right, an update on Alzheimer's disease, its causes and treatments, and particularly the question, can lifestyle modification help? Now, there is going to be a reasonable amount of detail in it, and that really is, I recognise, look, there's no exam, you don't have to regurgitate any of this, but it is there for people who want to listen to it. Pick up what you can. If it feels like a bit of a fire hose coming your way, just turn off for a minute or two. It is a complex subject, so while I want to be able to deliver it in a way that will enable people to be able to grasp as much as possible, it's not always going to be that easy not to include information, simply because that information itself is relevant. So as an overview, we'll look at dementia and its mortality in Australia. We'll look at the incidence of Alzheimer's disease relative to overall dementia. What is mild cognitive impairment? I'll talk about that later as MCI. Does it always lead to Alzheimer's? What's the cause or etiology of Alzheimer's disease? What's actually creating that disease in our community? Is it genetics? What's the risk factors, lifestyle, etc.? What is the neurochemistry? What's the neurobiology look like in people who are developing neurodegenerative disease like Alzheimer's? Then I'll look at what are the current treatments for Alzheimer's disease, particularly therapeutics. So symptomatic drug therapies, disease-modifying drug treatments, and new drug therapies, and then lifestyle treatments for both mild cognitive impairment, which is that prodromal stage or the early stage leading into potentially full-blown dementia, and lifestyle-based clinical trials for Alzheimer's disease or mild cognitive impairment in Australia. And there will be an opportunity, I'll bring those up and maybe people who may want to participate. So looking at Alzheimer's or the dementias broadly, we can see that they are the #2 cause of death, or the underlying cause of death in Australia as of 2021, our latest Australian Bureau of Statistics data. Interesting, for men it's #2, but for women it's #1 for reasons that we don't quite understand. And there's some theories on that, and I'm happy to talk about them in the question time if anybody has any questions. So women representing about twice the number of men developing dementia, and that dementia includes Alzheimer's disease, which we'll see makes up about 3/4 of all of our cause of dementia. The other thing that you'll notice is that lifestyle disease, all of those 5, the top 5 in males and females, are actually they're all represented the same, but just in slightly different rankings depending on your particular gender. But lifestyle disease plays a dominant role in all of those 5. So well worth paying attention to that. And dementia is the leading cause of death in Australian women, as I mentioned, second leading cause of death in men. So what is dementia? Condition characterised by persistent loss of intellectual functioning, especially with impairment of memory and abstract thinking, and often with personality change. I'll look at that a little bit later on, resulting from organic disease of the brain. In other words, something's going wrong that's causing the brain itself, the structure of the brain, the tissue of the brain, to alter and degenerate. Of the greater than 100 different types of dementia, there's 5 that make up the majority of disease in Australia. So 75% of dementias, or 3/4, is diagnosed as Alzheimer's. Vascular dementia comes underneath that, and there is often a crossover with people with comorbidities, Alzheimer's with vascular dementia. And Lewy body disease, which is Parkinson's, fits into that group, and the deposition of the protein Lewy body, and particularly in the musculoskeletal tract. And the frontotemporal dementia, and then alcohol-related dementia. But we'll be focusing on Alzheimer's disease particularly. In 2023, it was estimated that more than 400,000 Australians were living with dementia, and that's 1 in 64 people in our society living with dementia. That is a huge burden, not only socially, but certainly for the individuals and their families. So mild cognitive impairment, this is considered to be a transitional stage between normal aging and Alzheimer's disease, defined as the presence of memory complaint, defective memory impairment, abnormal for age, with relatively preserved general cognition and essentially intact activities of daily living. So you're not demented. I mean, people who have mild cognitive impairment notice there's something going wrong, particularly with memory impairment, but they can still think well, they can still drive, they can still carry on the normal activities of daily living. The annual conversion rate from mild cognitive impairment to Alzheimer's disease has been reported to be around about 1 in 10 to about 1 in 8, or about 10 to 15%. However, with time, that can be 80% of people with mild cognitive impairment will have converted to Alzheimer's disease, meaning that 20% of patients with MCI will remain stable or convert back to normal. And we'd certainly love to see that 20% raised significantly. And we think that there will be certainly things that should be tried in order to see whether this is possible. So for Alzheimer's disease, affects about 1 in 10 Australians over the age of 65, up to 1 in 3 or 3 in 10, Australians over the age of 85. So obviously age being the biggest risk factor. 2 main types of Alzheimer's disease. We have sporadic Alzheimer's, that's the most common, occurring in people over the age of 65. And then there's familial, ones where there is a significant genetic link, and this is happening to people much earlier, and that tends to progress much faster in their 40s and 50s. So the common symptoms: vagueness in daily conversation, lack of enthusiasm for activities once enjoyed, taking longer to do regular tasks. And that makes sense because the brain is just not functioning in quite the same way. And so they're taking a little bit longer to understand and decide. Forgetting well-known people or places, even family. Difficulty processing questions and instructions because they're not able to hold the information and manipulate it in the brain to come up with an appropriate response. And a decline in social skills, all as a result of that. Unpredictable emotions, and it's not surprising because these people are not able to process the information that's being sent to them. That's making them feel anxious, it's making them feel frightened, it's making them feel frustrated. And so it's likely that these are going to come out. And also there's a reduction, particularly as the disease progresses, in their ability to regulate their emotions. So the most common forms I mentioned of dementia is Alzheimer's, making up around about 3/4 of patients. And death usually occurs within about 12 years of diagnosis. Now, Alzheimer's occurs because there's selective damage to what we call the cholinergic neurons. So the brain uses a number of different neurotransmitters, acetylcholine being one. And for reasons that are not understood at this moment, at this time, it's the neurons that are using acetylcholine. They're the ones that seem to die off first. Now, eventually it becomes much more global, but certainly the neurons that are using acetylcholine start to die first. And these start to occur in places like the hippocampus, the frontal lobes, the amygdala. Now, I'll mention something about that a little bit later on, because the amygdala is significantly important with regulating some of our emotions related to anxiety and interpreting the environment and deciding whether or not we should be stressed over it or not. So the amygdala plays a big role there. So interestingly, that's one of the early ones that gets targeted. Nucleus acetalis and the median septum. Now, these all serve important functions, as I mentioned, for a variety of reasons, but they all play a role in conscious awareness, attention, and learning and memory in particular. So a normal brain is sitting there nicely filling out the brain case, and neurons, nice healthy look, transmitting information backwards and forwards, developing new synapses, making connections, making new memories as normal. Within an Alzheimer's brain, you get significant shrinkage, and that shrinkage is occurring certainly within the cortex. That loss of neurons is creating a bigger space for the ventricles, so they get larger. And as I mentioned, one of the areas that does shrink is the hippocampus, which has got a strong link to the development of memories, particularly long-term potentiation or those long-term memories. If you drill down a little bit further to the neuron itself, you'll notice a couple of things. Inside that neuron, there are these tau or neurofibrillary tangles, which is just what we call a hyperphosphorylation of the tau protein. Now, tau is a structural protein, helps with transporting things around the neuron itself from one part to the next, and they get lots of phosphate groups added to them when they start to develop things like Alzheimer's. Now, I'll talk about things like oxidative stress or free radical damage, but that actually promotes the development of these neurofibrillary tangles, that oxidative stress, or free radicals. So free radicals are the molecules that play the role in oxidative stress. In addition to that, you get extracellular, so outside the neuron, extracellular deposition or depositing of these beta amyloid plaques. So this is the molecule amyloid or beta amyloid. Now, that is a hallmark of Alzheimer's disease, been known for some time, but there's a couple of interesting things with beta amyloid. Doesn't always precipitate out in the brain where you get most neuronal loss. And the beta amyloid itself actually has some normal physiological functions. These are relatively new findings, but as people work further on them, they find that, well, beta amyloid as a protein may have a role in preventing infections, may also be useful in repairing some of the leaks in the blood-brain barrier. Now, you might not have heard of the blood-brain barrier, but you've got a blood supply that flows all around the body. Brain needs also lots of blood, and in fact, it's about 2% of the body weight, but uses about 20% of the oxygen. So it needs a huge amount of blood. And it's a very vascular organ. If you ever see just the blood vessels, it's actually all of them. It's a very dense network. But the interesting thing about the blood supply within the brain is that the blood itself doesn't just have access to the brain as it does with other tissues. What the blood vessels are, they're all coated they're wrapped around by specialized cells, which have what we call end feet that wrap around the blood vessels as they come into the brain space. And they will only let certain molecules come through and, of course, send certain molecules out again, particularly the waste product. And so that's called the blood-brain barrier. Blood doesn't have access. It's only allowing certain things from the blood into there. Now, interestingly enough, the body actually needs a very intact blood-brain barrier, because if it doesn't remain intact, then things can leak from the periphery, systemic circulation, into the brain and can itself cause problems. It'll cause more inflammation and that. And we'll talk about inflammation a little bit later on. So blood-brain barrier, very important in that. And beta amyloid is thought to play a role in keeping that nice and tidy, nice and tight. It also potentially, the beta amyloid actually promotes recovery from injury potentially, and has some regulatory function even within the synapses, so transmitting information backwards and forwards. So while beta amyloid is deposited outside, it can, and inside that you'll find that there's things like iron, zinc, copper, other immune cells, what we call microglia, macrophages, things like that, all get deposited in these plaques. So it might be that the beta amyloid is actually trying to do something positive in order to protect the brain, which is being constantly bombarded with things that shouldn't necessarily be there. So we know we get neuronal loss, we get these tangles, and we certainly get a greater deposition of these beta amyloid plaques, which themselves can create their own obstruction to normal cellular growth and neurotransmission. Now, immune activation, I mentioned there will be inflammation that's happening. It is also a hallmark of the development of Alzheimer's disease, the presence of inflammation within the brain. And just very quickly, inflammation is switched on for two reasons. Certainly in an adult brain, there are other reasons why in the developing organs you can have the immune system playing a role in some of the development, but we're talking about a developed adult brain. And within the adult brain, the immune system has other tissues get switched on for two main things. One is if there is an invading organism, such as a bacteria or a virus or a parasite or a fungus, etc. So to clear away any invading organism. Or number two, it will actually it will be switched on if there are debris to clear away. So if there's been some damage to the brain, then the immune system gets switched on to come away and clear away a lot of that debris, which can't be normally absorbed by the tissue around it. So the two reasons why inflammation happens in the brain, whether or not there's some sort of invading organism, virus, bacteria, etc., or it's clearing away debris that's been damaged and the rest of the tissue can't clear it. Now, we know that inflammation is happening within the central nervous system, within the brain of people with Alzheimer's. So what's actually causing it? We'll have a look a little bit later on. So there's four classic genes associated with Alzheimer's disease. There's familial Alzheimer's, which has these presenilins, presenilin 1 and 2, and beta amyloid, the amyloid precursor protein. Now, the main gene that's consistently associated with sporadic AD, so the thing with familial AD, that tends to come on a lot earlier, people in their, even in their 40s and 50s, whereas sporadic AD, which is the vast majority, happens in people over the age of 65. And ApoE is the only one that's really associated with them, but it's still not necessarily the major driver. But we'll talk about it a little bit later on, but that ApoE, having the epsilon 4, which I'll show you shortly, can actually increase the risk of developing AD between 3 to 12-fold. So in the ApoE for sporadic AD, this population over the age of 65, having a epsilon 3 allele is present in 50 to 90% of the healthy population. That's risk neutral, not considered to be a problem. Having ApoE2 is actually considered to be neuroprotective, so potentially a positive thing. But having an ApoE4 or epsilon 4 is considered to be a significant increased risk between 3 and 12 times. If you've got an ApoE4, because everybody inherits two, one from mum, one from dad, the having homozygous or E4E4, having two copies, is going to push your risk up closer to 12. Having an E4, but then the other one being an E2, you're probably down only at 3. Having an E4, E3, maybe sort of somewhere in the middle there. Really important thing to note is that having an epsilon 4 doesn't mean that you'll get Alzheimer's disease. There are many, many people with E4, certainly heterozygous, but maybe even having two copies who never develop Alzheimer's disease. And this is where we suggest that the environment plays a significant role. Now, I just wanted to also take you through in relation to the genetics of this. You'll notice I've circled in green the four that I've just talked about, the ApoE and the presenilins, etc. Now, there are many other genes that others have come up saying that there is a potential role, but I only pull out a couple just to give you a little flavour. In the case of oxidative stress, remember I've talked about that as being free radical damage. It's chemicals that will actually cause damage to tissue around it and therefore create its own havoc. Now, the ACE, or angiotensin converting enzyme, converts angiotensin 1 to angiotensin 2, and it's converting a molecule which is vasodilatory to one that's vasoconstrictive, potentially increasing blood pressure and all the associated problems with that. So ACE itself can certainly increase the potential for oxidative stress if you're getting damage to the endothelium. It can also, as a result of that oxidative stress, increase the risk of developing more tau deposition, so that hyperphosphorylation of tau, and I mentioned that in the earlier slide. If you've got oxidative stress, the production of the tau pathology increases that hyperphosphorylation. And also you can see with neuroinflammation, again, if ACE is up, then potentially with vasoconstriction, potentially high blood pressure, potentially you can also increase damage to surrounding tissue, certainly within the brain and small blood vessels. And so neuroinflammation may be actually initiated through some of those interactions, so it doesn't have to be solely that. The other one that I'll mention very quickly is the MTHFR, so methyl tetrahydrofolate reductase. It's commonly recognised. It's associated with what we call the methylation pathways relating B12, folate, B6 particularly, and the recirculating of things like S-adenosyl methionine, which gives up its methyl groups to then get recirculated through S-adenosyl homocysteine back through to S-adenosyl methionine. The important thing with all of that is, while the B12 and folate and the S-adenosyl methionine are necessary for sort of maintaining genetic integrity, cell division, maintaining signaling, particularly with epigenetic signaling, a bunch of things that they do. If you don't get good cycling, which the MTHFR gene does, you build up the molecule, one of the intermediates called homocysteine, and homocysteine can do an awful lot of damage to blood vessels. So you don't want it high at all. And you'll notice that it can increase neuroinflammation. Again, that's potentially because it's damaging blood vessels even from there. And you'll notice it's also listed with blood-brain barrier disruption at the bottom, or vascular damage. Again, linking through to the potentially the link with homocysteine and its ability to damage blood vessels. All right, so together these genes, now notice that interacting with environmental factors, they're not operating just on their own. There's got to be factors that are actually making a contribution. They could explain up to 70% of low just means late onset Alzheimer's disease, or we talked about it as being sporadic Alzheimer's a little earlier. So what are these environmental factors? Well, age, number one. And age, of course, is the greatest risk factor for the developing of the dementias and Alzheimer's also. Poor mental health, anxiety, depression. Notice I mentioned before that there was degeneration to things like the amygdala, which is related to control of some of the feelings in relation to things like anxiety. Some people can have a predisposition to it. Things in the environment certainly play a big role in whether people feel anxious, your ability to be able to get sleep, possibly even the amount of caffeine that you're drinking. Certainly caffeine can produce an anxiety-like state because of its because of the way it's affecting certain neurotransmission within that area. And anxiety for any period, it certainly is one link to the development of depression. Psychosocial health and of course depression has an effect on your ability to interact socially, as does anxiety, etc. So they all play well together. And it has been, you know, there's a number of papers that are coming out now showing that poor mental health may be one of the foundational risk factors for the pathology that ultimately ends up in a dementia. And we'll talk about that in relation to sleep as well. There's a lot I can say for each of these, but I'll try and be a little bit more succinct. For cardiovascular health, again, we talk about blood vessel health. That makes a lot of sense. High risk for heart disease, high risk for damage within the central nervous system, potentially blood-brain barrier disruption, lack of nutrients making it, and oxygen even making it into the central nervous system. Therefore, the potential of changes in the local pathology or local neurochemistry, which can predispose to inflammation and therefore a downstream production of some of the changes we see for Alzheimer's. I just mentioned here heart rate variability. Heart rate variability is also linked certainly through to anxiety as well. People who are chronically anxious have potential for low heart rate variability. Heart rate, everybody would know, roughly around about 60 beats per minute is a reasonably good heart rate. But that difference between the beats between 1 and 2 aren't all just 1 second. If they vary quite a bit, one at 0.5, another one at 0.7, the next one, 0.8, 1, 1.2, etc. So your heart rate variability is high. That's a good thing. Low heart rate variability tends to be a poorer thing. And there's links between, what we call the sympathetics, which are actually increasing heart rate, making you kind of stressed, relative to the parasympathetics, particularly the vagal nerve innervation and what the vagal tone is. So you want those to be in balance. High heart rate variability suggests that they are more in balance. Low heart rate variability tends to suggest that they're less imbalanced, and it certainly has a strong link to things like cardiovascular disease and also Alzheimer's. So hypertension, not surprisingly, poor cardiovascular health. Hypertension is a significant link. Anxiety also links through to hypertension, poor heart rate variability, and therefore, if it indicates things like vagal tone, certainly linked through to hypertension. And hypertension, there's suggestions that 5% of dementia cases worldwide are because of hypertension. Well, for a variety of different reasons, but one of which is you're doing damage to blood vessels, possibly doing small vascular damage within the central nervous system, creating its own problems that potentially lead to the metal dyshomeostasis and then the risk of oxidative stress and inflammation for a variety of reasons. Type 2 diabetes, well, this is of course is a high or it's an increase in blood sugars or a high blood sugars over a significant period of time. Now, insulin going up has its own risk factors, but let me just focus on the glucose just for the sake of time. But glucose itself, you don't want glucose being high. Glucose sticks to things, as we all know. If you spilled a sugary drink somewhere, it would be sticky. And that's exactly what glucose does to all the proteins in the body and in the blood. And the thing is that those proteins are your machinery, and they're complex machinery. You stick glucose to them, they don't work so well. And unfortunately, if they don't work well, then the body starts to break down the tissues in those regions. So type 2 diabetes creates its own problems and also increases things like what we call advanced glycation end products, which is part of this stickiness, which themselves can drive inflammation and oxidative damage, again, linking potentially through to inflammation within the central nervous system, the brain, and the development of dementia. Obesity, probably not just on its own, but of course obesity links through to poor blood sugar control, links through to hypertension, also links through to cardiometabolic disease and poor mental health. So it's not surprising that obesity is linked, because it has so many cross links with all of the others that I've spoken to. Being overweight on its own does drive its own, has its own problems, because increased nutrient intake relative to energy output, increased energy in relative to energy out, means that you get deposition of fat in multiple areas. And if it is visceral fat, it can also affect the function of organs, not just the liver and the pancreas, but you create your own inflammatory activity also, so increases inflammatory drivers, and for, again, reasons that I've just alluded to in relation to its effect on blood sugar control and potentially also hypertension. Not surprisingly, obesity is significantly linked. I don't need to mention very much about smoking. Heavy smoking, we know, or smoking in midlife, or smoking at any time really, you're taking in a huge number of very toxic chemicals, some all oxidative, or a large number of them having free radical activity. Not surprising, they damage blood vessels, having an effect on things like poor cardiovascular health, and then ultimately affecting blood vessel disease and potentially central nervous system blood vessels, and the potential for inflammation. Physical inactivity, again, you can link those to pretty much everything that I've put up the top there, certainly the obesity, poor blood sugar control, hypertension, poor cardiovascular health, and it's also linked very strongly through to poorer mental health. The other thing with poor inactivity, so physical inactivity linked to about 13%, they suggest, of Alzheimer's cases worldwide. But when you exercise, so physical inactivity is one thing, but physical activity actually promotes some very key things. Not only does it reduce some of the hormones associated with the continual development of anxiety and stress, but it actually increases the hormones associated with healthier brain production, or nervous links between our different neurons, so increasing our synaptic development of new synapses by things like brain-derived neurotrophic factor and glial-derived neurotrophic factor. So physical inactivity, you don't want physical activity appropriate for your age and fitness level. You definitely do want. And diet, and you've got the positives and the negatives. So the negatives, of course, where you have nutrient poor, energy dense, so just basically high fat, high sugar. And this is linked through to poor mental health, because generally if you're not feeling particularly good, you know, in a good mental space, you will, and many people do, they eat for comfort, and that will tend to be high fat, high sugar foods, because it gives them little highs and little positive feelings. But unfortunately, very poor, very bad for the body, and certainly bad for the brain. The other thing is that people may not be giving the brain and the body but the nutrients that it really needs, and so there is strong links through with the lack of things like B6, magnesium, B2, B1, B3, all of which have a significant impact on the capacity of neurons, neurotransmitter production, and normal central nervous system function. So several dietary patterns associated with lower risk of AD, including the Mediterranean diet and the Mayan diet, and I'll talk about that a little bit later on. High quality diet, as I mentioned, some of the B vitamins, but also the omega-3s, they're anti-inflammatory, so these are the essential fatty acids, things like EPA, DHA, and flavonoids, which are coming from your dark coloured fruits and veggies. They're really good for the brain. Alcohol, more than one standard drink a day, yes, has been linked with poorer mental health and potentially neurodegenerative changes. We published a paper back, and I think it was 2014 or 2015, going with what you see in the fluid that surrounds the brain, even with somebody taking one drink a day on a regular basis, or reporting one drink a day on a regular basis, we could see an increase in inflammatory cytokines within the central nervous system. And poor sleep or disordered REM sleep, that important time for when the brain is sifting and sorting memories. Poor sleep is certainly associated with poorer mental health, increased anxiety and stress, and it's also the time when the body is clearing away debris. Now, I'll talk about autophagy later on, but autophagy, like mitophagy, these are just really just the specialized, you know, rubbish removal services of the body and the brain, and they work at night, similar to ours in any society. So you want to be able to get some sleep so the body can clear away the rubbish. If they don't clear away the rubbish, you saw that beta amyloid can be deposited, or the tau protein can be deposited inside the neurons I showed earlier. When you sleep well, potentially they can be cleared a lot more efficiently. So sleep is extremely important. Now, low education, the link with low education really is more associated with cognitive reserve. So because the brain of somebody with less education tends to have not developed the same sort of dense neural networks required for problem solving as somebody who's more educated, then losing some of those networks has a greater impact on their ability to solve problems than somebody who's developed quite a dense network. And poor oral health, I'll only mention that just briefly, but if you have suffer from gingivitis or anything that might relate to potential infections within the mouth, they can be a source of systemic infection, which can also have an effect not only on cardiovascular health, which has now been well documented, but also in relation to blood-brain barrier function and potentially the health of the central nervous system. So very good to try and maintain a good oral hygiene and health. Okay, so just a couple of papers that have been linked through these, the gut microbiota and dysbiosis. So what about the gut microbiota? It's become more popular to talk about this. Causal relationship, not really there at this stage. However, there is a link between the health of the gut and potentially some of the things that could promote that beta amyloid aggregation, that neuroinflammation I've talked about, and oxidative stress. And some of these, go back to that slide. Some of these can include the production of butyrate. So good bacteria in the gut will produce lots of things called butyrate and other essential molecules like this. And this is very good because the cells that are lining the gut actually use the butyrate as a source of energy. And, so it means that they stay healthy. And if they stay healthy, it means that they maintain a good barrier between what's in your gut and what's in the rest of the body, because you really don't want much leaking over. Good gut bacteria also produce some of the good neurotransmitters. So one of them particularly is called GABA, or gamma-aminobutyric acid. And that's actually an essential, it's an inhibitory neurotransmitter. So we have excitatory and inhibitory neurotransmitters, and GABA is one of the inhibitory neurotransmitters that just help to slow the brain down a bit. So potentially very positive when people are feeling anxious and that sort of thing. This can actually help to modulate that or bring it back. So good gut bacteria can produce that. And if you've got bad bacteria in the gut, you can actually have production of things that are actually going to cause irritation to the gut, and potentially inflammation, which itself might cause leakage into the systemic circulation, ultimately having an effect potentially even on the brain. So as I've mentioned a couple of times, neuroinflammation really is an important finding within the development of the neurodegeneratives and Alzheimer's in particular. And what are the causes of these? Well, we don't know entirely everything, but I will make some inferences from some of the detail in the next slide. So what I'm going to try and do here is model this a little bit for you. So if we start off with what we've shown you is the A-beta, that beta amyloid, which is extracellular, and then the tau, which is the intracellular hyperphosphorylation of that structural protein. We know we get loss of neurons, and we get, and I didn't talk about it, we get astrogliosis. So we get, you know, a little bit of activation of what we call the metabolic support cells. But overall, you can see on the right-hand side, that's the Alzheimer's brain compared to the left side, which is actually the normal brain. And you can see that there's a loss of neurons. We have a lot less capacity in terms of our neural function. And so what's causing it? So when a brain comes in for autopsy, obviously this is a deceased patient. And so we're looking at what the end result is. We're not looking at the beginning necessarily. So we do see all of those. They're what we call hallmarks, particularly the beta amyloid and the tau and the inflammation. And I could show you also significant evidence for oxidative stress. So they tend to be the big four there. So oxidative stress, inflammation, tau, and beta amyloid. That's the big four that we see pretty much when we see a deceased brain that has degenerated and died as a result of Alzheimer's. But what's actually coming in behind it? Well, we know that we got decreased autophagy. Remember, that's the rubbish clearing service. They're less effective. Our mitochondria, you know, the powerhouse of the cell, you learnt that in science in high school. So the mitochondria isn't working so well, so we don't have as much energy to do the things that the brain needs to do. And we have less antioxidant capacity. So oxidative stress caused by free radicals, antioxidants actually block the free radicals. So they help to stop the free radicals from working, but we have less antioxidant capacity. Where would you get those from? So we have a compromised blood-brain barrier. I told you how important that was, not to let things from the systemic circulation get into the brain. That's been compromised, so we're getting a breach. Things that are getting into the brain that shouldn't be there, potentially increasing that drive of inflammation. So we got imbalanced nutrition. So very commonly we're finding with people with Alzheimer's and other dementias as well, that they've got a decrease in some of the very important molecules like our vitamins, A, C, E, provitamin A, which is carotenoid, and they also do a number of other things, but flavonoids and polyphenols. These are these antioxidants that are, you know, we get in our dark coloured fruits and veggies. We know, as I mentioned, that we've got an increase in glucose, and said that way the glucose is actually reacting with everything. It's binding to everything. It's sticking to things, and particularly things like protein, which stop those from working well. And that's not great. They generate their own free radicals. And we know there's a decrease in the B vitamins. I talked about B12, folate, B2, B6, B3. You could do a lecture on pretty much every single one of those. There's also poor lipid homeostasis. So we're not getting enough omega-3s in, that's the essential fats, but we're getting too much saturated fats, which drive its own inflammation. So we don't want that as well. We get an increase in visceral fat. I said that drives its own inflammation, also causes problems within tissue, the tissue of our different organs if we get the visceral fat. We get gut dysbiosis. I mentioned a couple of those things in relation to the positives and negatives, how good gut bacteria can affect our health. And then you've got metal dyshomeostasis. So in other words, we're getting iron and copper and zinc precipitating out or falling out in parts of the brain that they shouldn't, and they can create their own problems. And that's why, one of the reasons why we think beta amyloid actually chelates some of those and tries to get rid of it. But then too much of it creates its own problems. And having problems with the blood vessels, you can certainly get things like iron leaking, out if there's little blood vessel burst, but potentially copper and zinc as well. And there's hormonal, the hormones, we're getting the stress hormones increasing, but we're getting the good hormones, things like brain-derived neurotrophic factor and glial-derived neurotrophic factor not going up high. And psychosocial stress is doing that, so we get an increase in cortisol. We're getting inadequate rest, so again, the autophagy is not working. Inadequate physical activity is potentially driving, not only having an effect on our ability, our mental health, but also, as I mentioned, in some of the good neurotransmitters hormones associated with good neural function. Subclinical microbial infection potentially could be playing a role. Herpes simplex, GMB, Epstein-Barr virus, mycotoxins potentially coming from the mouth or the lungs. You know, these all can potentially play a role. If our blood-brain barrier is somehow being compromised, we may get some of this into the central nervous system and create inflammatory activity as a background. Decreasing sun exposure has a potential number of effects. Now, of course, we all know not to get too much sun, so we're not talking about that. But you need to get adequate amounts so that you can produce your vitamin D, have an effect on biorhythm, potentially even, I mean, serotonin gets produced in the skin, probably not making it in the central nervous system, but has other effects systemically. And even the potential for certain wavelengths having a positive down-regulating effect on inflammation. And surprisingly, it penetrates a little way into the skin and into the tissue, so it can have an anti-inflammatory effect. So getting some sun exposure regularly is a good thing. But again, all the caveats about getting too much and therefore creating skin cancer, which has its own problems. Neurotrophic factors, I've mentioned the BDNF and the GDNF before, and problems with excitotoxicity, which we could talk about later on with memantine if people have questions. So the point of showing you this is just that what we tend to see in the end result is, you know, we're looking at it relatively simply, and yet it's quite a complex business. And there's a lot of things that are going on. Potentially, if we could get a lot earlier, we might be able to prevent what we see as the later stage in the disease. So what are the treatments? We have currently no disease-modifying treatments at all. So that's nothing approved in Australia that will actually modify the disease. Yes, you can get some symptomatic treatments. So these are to downregulate a little bit of the symptoms of the disease, but they're not changing the course of the disease at all. And these are these anticholinesterases. What essentially they do is block one of the enzymes that actually tend to metabolize the acetylcholine. So if you block the enzyme that gets rid of acetylcholine, then you'll tend to have more acetylcholine around. It has its own group of side effects, doesn't change the course of the disease, doesn't slow the degeneration, but you might get some modest benefits from there. Memantine or Abixa is slightly different. It actually has, its target is actually the one of the excitatory neurotransmitters, which I'm happy to go into. I mentioned a little bit earlier the production of GABA, or gamma-aminobutyric acid, from the gut, essentially gut bacteria. GABA is an inhibitory neurotransmitter, whereas NMDA, or N-methyl-D-aspartate, is an excitatory part of the central nervous system function. And so it's exciting it more. And it's thought that overexcitation of the NMDA receptor is driving part of the death of the neuron. So potentially memantine can slow that down. Now that was on the market in 2003. It has you know, very modest effects also, but that is there potentially. So more than 200 drugs or promising drug candidates have failed clinical trials in the past decade, that's in the past 10 years. But there have been some new treatments approved in the USA, not in Australia. All of these are what we call monoclonal antibodies to beta amyloid. So you saw me show beta amyloid is depositing in the brain. For a variety of reasons we don't know, and it's thought that maybe getting rid of that beta amyloid we might get benefits. So on the 7th of June 2021, the American FDA approved aducanumab, produced by Biogen, and it was under significant controversy. I won't go into that detail. But since then, there's been a second one that Biogen have brought on the market, a second monoclonal antibody, lecanemab, approved in January of this year. And there's a third one that is expected, donanemab, to be coming on the market by Eli Lilly, to be approved by the end of 2023. Now, none of these are approved in Australia by the TGA due to a couple of things. Limited efficacy, in other words, there's not a great deal of data showing that it has a significant benefit for people with AD. And there is a significant increased safety concern. Now, one of those safety concerns is that up to 1 in 3 people develop what they call ARIAs, which is actually an amyloid-related imaging anomaly. And that really is just shorthand for edema. In other words, you're getting fluid on the brain, or you're getting a genuine hemorrhage. Both of those can be life-threatening, and people have unfortunately died from that. So there is a significant risk associated, and 30% of people who are on it develop these, and potentially that risk goes up with time. So beta amyloid, this is where the target is for the drugs that are showing more recent interest, but again, it's way down the track. Possibly could we go earlier, possibly targeting inflammation. Many are looking at that, and that's still a fruitful area to look. But looking at the complexity and the number of ways in which inflammation may be initiated within the brain, while there's only 2 basic causes, remember I said they were to clear away debris, or the immune system is switched on to either clear away debris or fight some sort of foreign invader. There can be a number of ways in which the brain itself can be being damaged, and therefore switching on the immune system as a result. So what are the observations so far? Alzheimer's, it's a complex disease with multiple metabolic and environmental contributors. Most cases don't have a specific genetic abnormality. The current drug therapies are unable to prevent the progression of the disease, and neuroinflammation with its oxidative stress is a key driver of neurodegeneration. So could lifestyle intervention be effective? Now, I think that there is certainly evidence that it can be. We've been looking at it for a little time. 2014, Dr. Dale Bredeson, who's a neurologist from the US, now working with University of California, Los Angeles, published a series of case studies showing 9 out of 10 of his Alzheimer's patients using a multimodal intervention displayed significant improvements after 3 to 6 months, which were maintained after 2.5 years, which is pretty impressive. You want to, first of all, increase the autophagy, so made sure that they fasted each night and got a good night's sleep. They went to bed 3 hours, or at least they finished eating 3 hours before bedtime. They didn't have high amounts of simple carbohydrates, so sugars, in order to help to reduce the inflammation. As I said, made sure they got plenty of sleep, at least 8 hours. They exercised between 30 minutes and 60 minutes per day for at least 4 to 6 days. They had brain stimulation, made sure that they optimized their D3 and their K2. Acetylcholine is just one of the ones making sure that they've got increase in acetylcholine, gave them omega-3s, and increased their sirtuin function. Now, he gave them resveratrol. We would argue that there's probably better ways of doing it than that. Probably the B3s might be a better way, giving things like an increase in NAD, and reducing their personalized stress, so reducing their hypothalamic pituitary adrenal axis, so those stress hormones, those anxiety-associated hormones. So others have shown some significant benefits also of lifestyle, prevention, diagnosis, and treatment of Alzheimer's. While broadly, several hundred therapies, as I mentioned, been discontinued due to lack of efficacy in recent decades. Knowing that stress plays a major role, lifestyle factors are being increasingly recognised. So it's interesting in this 2021 review, talk about the FINGER trial, which was from Finland. And Finland used dietary intervention as well as consumption of whole grains, fruits, vegetables, and low-fat options as far as their oils. replacing things like milk and meat. They also got them to do exercise and got some very good benefits for their neuropsychiatric battery after 2 years. In the PREDIMED study, this was actually using the Mediterranean diet, and that intervention showed better global cognition performance after 6.5 years for those people who were taking that sort of a diet. Now, the DASH diet is a diet associated with reducing hypertension and showed greater improvement for executive function, memory, and learning. And the MIND diet, which is actually a combination of the Mediterranean diet and the DASH diet, reported to reduce the incidence of AD. In an Australian population associated with that study, the DASH diet, but not the Mediterranean diet, was found to be associated with reduced odds of cognitive impairment. So, but reducing hypertension is known to be a very positive contributor. Potential prevention of dementia across 2 decades. Rotterdam study, 7,000 enrolled, followed for dementia until for 10 years. So this is just a prospective study. They looked at their population attributable risk for things like overweight, hypertension, diabetes, cholesterol, smoking, their education. They also looked at things like stroke, coronary heart disease, and heart failure, as well as atrial fibrillation. And they did find and concluded that a substantial part of dementia cases could be prevented if modifiable risk factors would be eliminated. Another study, longer-term effects of diet and exercise on neurocognition, the 1-year follow-up of the Enlighten trial. This is from 2020. Primary findings after 6 months. Participants randomised to exercise demonstrated better performance in the executive function domain compared to the non-exercisers. So not surprisingly, exercise, we say, puts up things like the brain-derived neurotrophic factor. Largest between intervention group differences were observed for participants randomised to both the combination of exercise as well as the DASH diet. Remember, the DASH diet is the one that's reducing the hypertension. So at the 1 year, for those who had a cognitive impairment, the CIMD group, and cardiovascular risk factors, exercise for 6 months promoted better executive function compared with non-exercisers. So dietary patterns in midlife, just a couple of other studies before I finish. Prospective study in Chinese adults. Basically, a good diet in midlife resulted in about a 30% reduction in the risk of dementia later in life. Heat therapy might be considered a little bit peripheral, but interestingly, whenever you exercise, your core body temperature goes up, and you do activate what we call heat shock proteins, which have their own beneficial effects in reducing inflammation and having positive effects in terms of what we would consider cardiovascular and central nervous system health. But this heat therapy is also associated with going into a sauna, a steam sauna or infrared sauna, and significant benefits for cognitive function, even for the aging brain. Of course, there are some caveats also. I mean, you don't just jump into a sauna if you've got multiple comorbidities, so being conscious of how all of those to tie in, but there could be benefits coming in there. Intermittent fasting, and this is giving the body a true break from eating anywhere between 12, 16, even 18 hours a day. You do get significant benefits in this 3-year study. However, one of the things to keep in mind is that as people get older, their capacity to take in nutrients and absorb those nutrients tend to get less. So just need to make sure that if you were going to do intermittent fasting, that when you are eating, that those who are older make sure that they are eating a very high nutrient dense diet to make sure that they are getting all of the nutrients that they do need in that reduced window of nutritional intake. And finally, just rheumatoid arthritis. Because rheumatoid arthritis is a systemic inflammatory condition, it's thought that it could play a role in promoting cognitive dysfunction or neurodegeneration. And it's interesting that the jury is still out a little bit on this. I mean, this is a 2023 review, but essentially, 5 studies were showing that yes, there is a significant relationship between rheumatoid arthritis and the development of dementia. 5 studies were equivocal, which means they didn't show they didn't, but they didn't really show strongly that they did. And then there was 1 study that actually showed the opposite. So it does show that depending on the cohort chosen and potentially some of the measures that are used to assess dementia and broadly, I guess, inflammation related to the disease, it can impact on whether or not it's having an effect. But it is one to watch, and certainly having working to reduce the inflammation associated with rheumatoid arthritis would be a positive thing. So what are the conclusions? The neurodegenerative dementias have complex heterogeneous pathologies with still largely unknown etiology, that is, so we don't know the cause. There's currently no effective disease-modifying drug therapy. Multiple treatments involving lifestyle modifications in the early stages of the disease currently provide the most promise in disease prevention and modification. And as far as the multimodal clinical trials, well, there are 2 happening within the Sydney region. Now, this first one is actually happening within the Sydney region. The site is at Macquarie Uni, which I'll show you shortly. But if you were in Western Australia, it is also, I think it's University of Western Australia there, but I've had to check that. So this is the AU Arrow study. It's essentially the Australian site for what the study I mentioned earlier, which was the finger study. It was a very famous study from a few years ago from Finland, and well worth being involved and certainly seeing what the results were. Contact details there with Dr. Stephanie Fuller from Macquarie Uni. The other one is actually our study, Brain Enhancement Strategies. It's a 6-month multimodal program as well. Facilitated behaviour change. We'll be recruiting till the end of next year or November next year, but study starting early in 2024, and so people are encouraged to provide an expression of interest. They can either contact me directly or via email. I look forward to your questions.